we start our webinar today. This is our second edition of ACNS Fujita Health University IVR web seminar. Today we have two speakers with us, Professor Ichiro Nakahara, who is a professor of Department of Neurosurgery, Fujita Health University Bantane Hospital, Nagoya, Japan. And we also have Professor Azam Said Ahmad, who is an associate professor of neurological surgery, radiology, and general surgery, Foundation of International Education in Neurological Surgery, and also Comprehensive Brain Tumor Program Co-Director, Multidisciplinary Pituitary Program Director, University of Wisconsin Department of Neurological Surgery, Wisconsin, United States of America. And today we have our chair, Professor Feng Su, who is an associate professor of the Division of Microsurgery, Interventional Neurosurgery, Department of Neurosurgery, Huashan Hospital, Shanghai Medical College, Fudan University, China, and our Professor Yoko Kato, who is a Deputy Director of Fujita Health University, and also Head of Department of Neurosurgery, Fujita Health University, Bantane Hospital. And our discussion for today is Professor Mihensky, who is a chairman, a president of Hospital Astana, Kazakhstan, also a vice president of the National Medical Association of Kazakhstan. So before we start with our first speaker, may I request Professor Kato to give a short welcome address, Professor.
Okay, thank you very much for joining today's webinar. So this is our very proud of this the webinar, because today's Professor Nakahara Sensei is the head of the endovascular section of the Bantane Hospital. He does so many good work, I think. So we are very much looking for his lecture, and also the professor as well. Also, we are very much expect your talk. Thank you very much.
Thank you to Professor Yoko Kato. So without further ado, I would like to invite Professor Feng Zhu to invite our first speaker, Professor Ichiro Nakahara, to give his first lecture. Professor.
Okay, may I start my talk? Okay, so I'm going to share my PC. Can you hear me?
聞こえます。
Hi. So today my talk is regarding the dual AVFs. The case is a little bit complicated, but I'm going to talk as much as the time can affordable. And, so as you know, dual AVFs, DAVFs can occur in any place in where there is a dural matter. And variations such as interosseous type or radicular type can be possible. So it's very, very complicated, and it consists of 10 to 15% of the brain AVM, and pathogenesis includes spontaneous venous sinus thrombosis, post-craniotomy, brain tumor, head injury, or maybe due to some other reasons. And classification is very important, such as Cognard classification, Borden classification, Lalvani classification, and some other classification, but the very famous is Borden and Cognard. And the key to this classification is the venous drainage pattern. Particularly very important is such kind of left meningeal retrograde, left meningeal venous reflux. This case is transverse sigmoid sinus dural wave with an isolated sinus segment. This is classified as a Cognard type 2A plus B, Borden type 3, Lalvani grade 3. And dural waves is such a retrograde left meningeal venous drainage, RLVD, presents as aggressive neurological presentations in 20 to 30%. And annual mortality rate is about 10% in some reports. And the rebleeding rate during the first 6 weeks after the initial hemorrhage is 30%. 5%. So bleeding rate and rebleeding rate is rather high compared with diseases such as AVMs. So high-risk dural AVFs require immediate aggressive treatment. This is the report from some investigators, and according to the corneal type and Boden types, hemorrhage rate and aggressive symptom rate is such as 48% and 79% by Boden type 3. Yeah, so in these cases, we need to treat the patient by some method. So this is a little bit old report from the United States, World Neurosurgery, 2010, and the surgical treatment of dural AVFs consists of endovascular treatment, transvenous, transarterial, combined, or maybe sinus PTS stenting for the occluded sinus combined with the dural AVFs, and of course, direct surgery such as renal ligation, surgical isolation of the affected sinus, and of course, maybe our next speaker will talk about this, but hybrid transvenous or transarterial embolization using these kinds of techniques, and radiosurgery. But radiosurgery is usually not used for the Boden type 2 or 3 aggressive, riskier dural AVFs because radiosurgery takes some time, time-consuming nature. Yes, this is a report from the maybe 10 years or 15 years ago, but now the situation is already changed, and concept should be changed. At that time, there was a question, endovascular treatment can be an alternative for surgery in many cases. In this paper, they said surgery required, such as the anatomically poor access by endovascular means, including anterior cranial fossa or tentorial dural AVFs, failed endovascular treatment, or poor candidate due to the hemorrhage, or such as several conditions. They insisted the importance of the surgery. Yes, but now endovascular treatment can treat most of dural AVFs. This is my answer. And surgical treatment of dural AVFs have changed so much in these recent 10 years, partially due to the application of onyx instead of the coils and the NBCA to the treatment of dural AVFs. In Japan, government approval was obtained to use of the dural AVF, to use the onyx for the dural AVFs already in 7 years ago. So the treatment is government approval and covered by the national insurances. Of course, in some cases we need hybrid approach or direct surgery, but it's a very, very, very few. One case is, as you may know, developed in Japan and by my teacher, Dr. Taki, already 30 years ago or more, and it went to the United States and name was changed to Onyx. But anyway, it's a mixture of IVR and DIMSO and tantalum powder. It's a very nice embolic agent. So from now on, I'm going to present 3 cases of a very rare posterior fossa dural AVFs and talk about the anatomical considerations and the technical nuances for these cases. Maybe a time will be short, and I need to stop in part way. Anyway, I start the case. This is the first case. This was a very unique case, dural AVFs at the posterior condylar canal, presenting as a pulsatile tinnitus. The patient was 39 years ago male, and he developed a very acutely onset pulsatile tinnitus 2 months before he came to us, and otherwise he was neurologically intact. And the MRI shows here the vascular shadow on the right skull base. And this is the source image of MRI angio, shows here the vascular intensity. This is the right side. CP angle. Here is the internal auditory canal. So posterior to the internal auditory canal, the location consists of with the posterior condylar canal. And this is the bony CT image, shows the enlargement of the condylar canal, posterior condylar canal like this. This leads the posterior condylar vein to the cranium. And this is the angio on right external, right vertebral, and you can see the here the shunt, AV shunt lesion, supplied by the right ascending pharyngeal and the right occipital artery, like this and like this. And also there are some branches from the right vertebral artery, anterior meningeal artery, and C1 cervical dural branch. And this is the enlarged super-selected view of the ascending pharyngeal artery, and the lateral view. You can see the new meningeal trunk of the ascending pharyngeal artery like this, and here the hypoglossal canal, and here you can see the shunted pouch, and this is the posterior condylar vein, and now here external canal, suboccipital cavernous sinus, and they're going down to the deep cervical vein. So venous anatomy is a little bit complex, and some physicians are not familiar with these kinds of skull-based veins. But anyway, the shunt was here, located in the posterior condylar canal, and we need to treat. We may need to treat, but this is a Boden type 1, so this is not a very dangerous lesion. Sorry about this. But the ascending pharyngeal artery transarterial is very dangerous, and it contains dangerous anastomosis and supplies the cranial nerves, so making transarterial embolization contraindicated, particularly using the liquid material. So we may be able to go from the venous side to here. Diagnosis was a posterior condylar canal dural AVF Boden type 1, fed by these arteries, and the shunt point is here. This is a super-selective angio during the endovascular treatment, but you can see the very fine networks here in the right posterior condylar canal, and the vein, draining vein was posterior cervical vein, deep cervical vein, or some other routes like this, observed like this. So this is the lateral view, 3D, ascending pharyngeal, shunting point, and this is the venous route. So we went up through this route to the shunting point like this. This is the artery catheter, and now we are going to go up here, deep cervical, occipital cavernous sinus, and through the posterior condylar vein to the shunting point. So it was not very difficult because the root is very large, thick vein. So this is the microcatheter reached here to the shunted pouch, and we use that. In this case, we only need a coil. Maybe onyx can be used combined in combination, but coil was enough. So after the coil embolization, a shunted pouch and some part of the posterior condylar vein, the shunt was disappeared and the complete evaluation was obtained. This is the CT taken after the treatment, showing the coil mass in the posterior condylar canal. So this was the Boden type 1, not very dangerous case, but the treatment was very straightforward if you understand the venous, particularly the venous drainage anatomy at the skull base. Next case is this is also a very unique case, a trigeminal radicular AVF. Precisely, this was not a dural, but a radicular AVF. But this was very unique because this was presented at the microvascular decompression surgery. 58 years old female, sorry about this. And she presented a very acute onset of the right trigeminal neuralgia. For 2 or 3 months, and she developed a very strong pain. actual right face, and he came to our department, and this is the pre-operative images, and I could not imagine the AV shunt disease, and you can see some vessel, but these vessels were seem to be offending artery to the trigeminal artery. So endoscopic microvascular decompression was performed. Sorry. Yes, this was done by Professor Komatsu in our department. This is the right side petrosal vein, and the dura is very clean. And this is the trigeminal artery and trigeminal nerve. You can see some very irregular fine vessels. And again, expecting the dura, but no abnormal vein at the dura. And he's dissecting around the petrosal vein and the ICD video angiography showing these. Yes, you can see the very fine light at the vessels on the surface of the trigeminal nerve. So here, yes, this is the enlarged. This is, I think this is a part of the draining vein. Sorry about the video movement, but this is the final scene. Yes, after, yeah, you can see the shunting. So after this Professor Komatsu stopped the surgery, and he sent the patient to us. And this is the DSA taken after the 1 day after the microvascular surgery, decompression surgery, and right vertebral. This is the PCA, right, is CA, and this is trigeminal cerebellar artery feeding the right trigeminal nerve. This is the ICA, and you can see the shunt disease here. And after the vascular triangle, this is the drainage, petrosal vein to the superior petrosal sinus, and some part to the inferior petrosal sinus. So this location must be a shunting point. You can see this one, and this is the lateral. Probably this is the maybe this shunting point is this petrosal vein and SPS. This is the same kind of a magnified view, and this is the MIP maximal intensity projection map view, MIP view of the 3D angio. A little slightly better than the conventional DFC, but maybe a shunting point here. And at this stage, our diagnosis was the AV shunt on the ventral surface of the right trigeminal nerve and fed by these arteries. And the draining vein is petrosal vein to the superior petrosal sinus. So this is the left meningeal vein, free vein in the subarachnoid space. So this was the Borden type 3, very aggressive type, required the treatment. So we did the precise imaging study. This is the MPR image of the 3D angio. You can see the shunt point here. This is on the surface, ventral surface of the right trigeminal nerve. So we did the endovascular treatment 3 days after the microvascular decompression surgery. Under general anesthesia, we used this very small caliber microcatheter and used the NBCA, and the initial embolization was successful. This is the right trigeminal cerebellar artery. You can see the tip of the microcatheter here, and injected some NBCA here, and the NBCA penetrated to until this position. So it was very nice. And after the initial first embolization, this route was occluded. But still, we have some feeding from this ICA, right ICA, and this is the subarcuate artery of the right ICA. So we yes here. So we went again through the ICA to this point. Unfortunately, after when we did the super selective angio, there was some extrapolation, so we quickly used the additional small amount of NABCA and occluded this pellicle. Sorry, I skipped this, and this is the final angio. You can see some aviation here, but almost disappeared. The patient was full conscious without no paralysis, and hearing was okay, and the facial palsy was not observed, but some sensory disturbance on the her right face, and some dysarthria. And the MRI shows a small amount of acute infarction in the right pons. But very, very interesting was, it was the trigeminal neuralgia had resolved by the following day. And all of these deficits improved in several weeks. And this is 3 months follow-up DSA, showed no AV shunt, so this one was completely cured. So it was very fortunate for us and for the patient that the lesion was disappeared and the trigeminal neuralgia was also resolved completely. So this was a very interesting case. I think our diagnosis, trigeminal radicular AVF, is correct due to the angiographic findings and also the interoperative findings during the microvascular decompression. We may be able to treat by a transvenous emulation. Radial surgery, I don't think it's a very good idea, and direct surgery already we have done by the endoscopic method. So maybe transvenous, but transarterial was a very nice approach. So maybe the time shortage, I may need to, I have to stop here. I have another very interesting case. Was the canadura AVFs presented by the hearing loss, but it takes maybe 10 or 15 minutes more. So I would like to skip this case. I'm going to present this in the next occasion, next chance, opportunity. And I am going to show the final slides, 2 slides. Final key message today is that, sorry about this. Yes, today's key message is that the preoperative diagnosis required for the appropriate endovascular treatment to include the precise analysis of the feeding artery, draining veins, and also it is very important to identify the accurate location of the shunting point. And final determination of the treatment indication should be based on symptoms and findings, particularly avoiding corneal classification. Aggressive feature dural-based Boden type 2 and 3 should be treated as soon as possible, probably by the end of the treatment. So according to this, modality of angiographic diagnosis is very important. And to determine the accurate location of the shunting point, advanced DSA imaging protocols is very important, indispensable. Conventional 2D DSA is not very satisfied. It may be insufficient. 3D DSA and high-resolution cone beam CT using the angio machine, particularly NPR image using the thin slice, and source image diagnosis of the 3D angio with the bony structure fusion is a very, very exclusive way for the accurate diagnosis of the dural AVS. Okay, thank you very much for listening my talk. Thank you.
Thank you to Professor Nakahara. Probably I would invite our chair, Professor Zhu, to give his comment. Professor.
Thank you. Thank you for Professor giving us such a wonderful cases. The first case is a rare disease of the DAVF in the posterior fossa, and it was treated by the transvenous approach and was successfully obliterated. But I have the question of the case 2. The
Yeah.
case 2 is formed by the MVD operation, and from the DSA, the 𝐷𝐴𝑉𝐹 was supplied by the territorial branch of the 𝑆𝑐A and 𝐸𝑐𝑎ℎ. So the diagnosis, I'm not sure whether it's 𝐷𝐴𝑉𝐹 of the tentorium, and I read a reference of the artery was described as the Warden. I didn't remember the reference. Is described the tentorial branch of the SCA, superior cerebellar artery. So maybe it's a tentorial 𝐷𝐴𝑉𝐹. I'm not sure. Okay. So
Okay.
it's very good case and excellent. Thank you.
Thank you very much, Professor. Regarding the second case, the first pedicle we embolized was actually was not the SCA tentorial branch, but it comes from directly from the basilar artery, and it is called the trigeminal-cerebellar artery, sometimes observed during the microvascular decompression surgery, but it is rare to be seen in usual angio. But this is the dural AVF, and trigeminal cerebellar artery was very large, so we could find the pedicle. And as like you, we thought that there might be some feeder from the SCA tentorial branch, but actually after the embolization, there was no feeding artery from the superior cerebellar artery tentorial branch. And also in the operation, we didn't see any abnormal vessel on the surface of the dura and the tentorium. So we don't think that shunt was located on the surface of the tent, but probably on the ventral surface of the trigeminal artery. Okay.
Yeah. Anyway,
Thank
it's completely obliterated by the transarterial approach. Thank you.
Yeah, thank you.
Thank you, Professor Zhu. Now we probably hear from Professor Bizinski. Professor.
Hello. Good day in Japan. Good evening. I hope you mentioned me, but pronunciation bit different. Munjolka.
Okay, sir.
Thank you. About these cases, all done with a great success. Thank you. And the last case with a small complication. It's a part of life, and it's possible in all arterial catheterization, and we all the time ready to inject something, and successfully it was branch for dural fistula, and the patient recovered completely. And in our practice nowadays, we are doing selective, as much as possible, selective venous approach. And I know in many hospitals, in many centers, at the time of dural fistula, our colleagues usually doing sinus occlusion. But nowadays, we did several cases. We are going to the shunt point super selectively, and it's possible to inject retrogradely. And I think the last case was some of that candidate. It was possible to go through the superior petrosal sinus, through the transverse and sigmoid sinus joint, and could be occluded retrogradely. But it's need little bit time, and from the large sinus to go to the small primary vein usually a little bit problematic. And as I learned from Professor René Chapeau, sometimes it's possible to use diagnostic catheters to go selectively from the sinus to the primary veins. And I think in many cases of dural fistula, the venous approach may be more safe and should be first approach in dural fistula cases. But all cases done with great success. Thank you, Professor, for sharing your experience. Thank you.
Thank you very much for your comment. I totally agree with you. Thank you very much.
Thank you, Professor. Probably we can hear a comment from our second speaker, Professor Azam. Professor.
A very nice presentation of those cases. These are, as Dr. Nakahara mentioned, very, very rare cases. And each one is interesting and unique, I think, these fistula cases. Obviously, they can be classified and categorized various ways, both with their Borden classification, Conyard classification, etc. But ultimately, the key points are that it's important to understand the dangerous anastomoses, as was mentioned. I was very interested to see how you're going to approach that, since there are those dangerous anastomoses from the ascending pharyngeal. And as Dr. Źdźwiłki mentioned, that the transvenous approach is so robust. Oftentimes, the catheters and the microcatheters that we used to have, and potentially also the imaging capability, was not very great to be able to see these small connections sometimes. But now things have improved dramatically with our ability to visualize the connections, and then that allows us to then have the opportunity to navigate to those areas. So we really also have been really approaching these fistulas from the transvenous side, and with good success, and I think a lot more safety as well. So I really enjoyed both of those cases, and also the third one, very, very nice cases. Thank you for sharing them.
Thank you very much.
Thank you, Professor Azam. Probably one question from me, Professor. I recently attended a webinar by Professor Komatsu, and he thinks that venous structure would never cause conflict, neurovascular conflict, compression to the nerve. And in such cases, do you think that if we're going to treat for microvascular decompression cases, will you think that being done, if there is a facility of hybrid OT, would be advantage? Example, the same case, if we can do angio on table, would it be able to treat surgically too? The same case, Professor. Thank you.
It must be a very nice approach. I think if it's a hybrid or is available, maybe we could treat the efficiently in the same session after the microscopic decompression surgery. Unfortunately, we don't have the such facility yet in our hospital. Maybe in several years. And Professor Zhang may talk about this in the next talk. Thank you very much.
Thank you to Professor Nakahara. Any comment from Professor Kato, Professor?
No, I don't have, because we work together. So the Nakara Sensei, he is very good at also read the angio very precisely. So that's very, very important for a young neurosurgeon. Then he established his treatment way. So that maybe, I think Bangladesh, YNS is listening. It's very, very important. He collected so many cases in his history. So thank you so much.
Thank you, Professor Kato. Now, thank you, Professor Nakahara. Now
you.
we move on to our second speaker. May I call upon Professor Zhu to invite our second speaker, Professor? Professor Feng, you want? Yes.
Sorry.
Yeah, yeah. To
What?
invite our second speaker, Professor.
Our second speaker.
Professor Azam is there. Yes. Probably I can read out his topic again. He will speak on hybrid neurovascular intervention, Professor. Please.
Thank you for the opportunity to speak to you today. So this is, thought I would narrow the topic a little bit since the time was only about 15 minutes, is what I was told. Is that correct? 15 minutes?
Yes, Professor.
Okay. So, so in this era of endovascular therapy, there are still opportunities and reasons to still approach these lesions with open surgery and even when the main indication may be endovascular. And I'd like to present some of these indications here. So we approach the carotid in cases of stroke when patients have a severe tortuosity or failed femoral or radial access. We can access the carotid directly. And I'll show some of those situations. And then another indication in stroke specifically would be common carotid artery or internal carotid artery occlusions, where the carotid terminus or the internal carotid artery bifurcation in the brain is open. In those situations, the anterior communicating artery is still providing good cross-filling to the middle cerebral artery. An antegrade approach may dislodge the clot and result in more distal embolization. And in those cases, select cases, a direct carotid approach may be beneficial, whereby the direction of flow is back out through an arteriotomy in the carotid. And so to the point of the last talk, we actually are spoiled here. We have two hybrid operating rooms. We have an ARTIS Q system, and we have an ARTIS Icono, and these are situated side by side through the door that you can see here in the picture on the right. So we have ample opportunity to be able to do these approaches with facility. So in the cases of vascular tortuosity, in many cases of stroke, it's like this. And in most cases, I would say, the catheters and the tools have progressed to the point where we're just going down the river very easily, be able to get our catheters navigated to the point of occlusion. And some cases are more like this, where the vascular anatomy is very tortuous, and we are trying to find our way to our goal here. And it's very, very difficult and arduous to achieve that. And I'm sure all are familiar with the aortic arch elongation classification, type 1, type 2, and type 3, based on the outer and inner curvatures of the aorta. And this has very significant implications for our ability to have the pushability that we need to be able to access these occlusions in the brain. So superimposed upon this aortic arch elongation, you can have proximal and distal tortuosity. So you can have cases where as you progress on this left panel from A through D, you can see progressively more difficult, more tortuosity in those vessels. People have classified these in various ways, as coiling or kinking. And these are important because they limit our ability to navigate our catheters, our wires, and then more importantly, our catheters to the point of the occlusion. And can be prohibitive in our ability to achieve that result. In particular, the combination of proximal and distal tortuosity in the same pathophysiology that results in proximal tortuosity will result in distal tortuosity. And so these often go hand in hand. Superimposed upon one another, For instance, in this bottom, going from least tortuous in A to most tortuous in H, you can see that the tortuosity becomes more and more severe, and this makes it progressively more difficult to be able to navigate the catheters as they go. There's many reports, ours and others, of tortuosity as predictors of either longer procedural times, delayed in the first pass effect or delayed recanalization, and also tortuosity predicting hemorrhage, amongst other things. So tortuosity is an important factor that we want to address and can result not only in prolonged times, decreased recanalization rates, and also can result in hemorrhage. Here's a case where you can see that the aortic arch, this is a type 3 arch, and how difficult the access is in these types of situations. So for me, I set a limit of 15 minutes of access time. If I cannot achieve the goal in 15 minutes, of course, these are cases of acute intracranial occlusions, and we need to move it along and get the job done rapidly. And so in these cases, I think that it's oftentimes much more straightforward to simply access the carotid. We can do this very easily with ultrasound guidance, 5 French micropuncture access, and then I prefer using this sheath, although many can be used, but 6 French 40 centimeter destination sheath made by Terumo. But any other standard guide catheter will work as well. We punctured this at a 45 to 60 degree angle. And then we navigate this into either the internal or more commonly the external carotid artery to gain our micropuncture access, and then it's quite straightforward thereafter. You can see once the access is obtained, this is really terrific access in the sense that we can get our guide catheter up to the base of the skull here, almost to the pubis segment. Certainly distal cervical, and that allows us to recanalize this vessel very easily. At the end of the procedure, I prefer, well, some people have used closure devices such as AngioSeal and others. I prefer just to do a carotid cut down and close the carotid primarily. I think that results in the best outcomes and the lowest likelihood of complications with the closure devices. I think it's asking a lot of the closure device to be able to securely close these holes. Plus, I worry about the concern for dissection in those cases. And if the closure device fails, obviously expanding hematoma in the neck is much more different than expanding hematoma in the femoral region. Therefore, I prefer a carotid cut down. It takes about 15 minutes to cut down to the carotid and put that stitch in, and I think it's time well spent. The second situation is for cervical carotid occlusion, where the main site of the occlusion is the cervical carotid. And in these cases, the pathophysiology is often a ruptured plaque, where the carotid artery has some thrombus. You can see here there's a calcification here, and you can see the common carotid artery is occluded here. Certainly, this could also occur distal to the bifurcation in the internal carotid artery due to plaque rupture at that point. In this case, earlier on in my career, the standard teaching would be to try to navigate this endovascularly, which I did. And I advanced a balloon, as you can see here, inflated very nicely. I thought that this looked like a great result. And you can see I have a distal embolic protection device and following all the rules as it would be, only to realize that there was a significant dissection that had occurred unbeknownst to me. Obviously, this is a big deal problem if the carotid is dissected from this point, and this patient went on to have a very large stroke because of that dissection there. So I think really it comes down to where the site of the occlusion is in as well. So in the case on the left, you can see the carotid is occluded in the cervical segment extracranially. You can have intracranial occlusion proximal to the bifurcation. And I think this is an important one where the ACOM, depending on its size, is providing important collaterals. And as we navigate through this thrombus, we risk dislodging this thrombus and making the situation potentially worse for the patient, taking away their ability to provide collateral supply. The situation with a terminus, in this situation, direct carotid access would not be important because the terminus lesion is serving as the backstop or the protection for emboli. The reason why carotid access is important in this situation is that if you access the carotid in the neck, obviously the directionality of the flow, the forces are very different. In this situation, if the common and external are occluded and we access the carotid here, the direction of flow will be pushing the thrombus out towards us into our field, as opposed to if we approach it endovascularly where the direction of flow is antegrade. So in situations where we have, such as these, stents can obviously be placed as well. And the symptomatic intracranial hemorrhage rate has been reported to be upwards of 25% when these patients have received TPA. So in this case, this patient received TPA. You can see the very large mismatch ratio for this patient due to a carotid occlusion. We administer the patient cangrelor or a similar 2B3A inhibitor on the table in addition to aspirin. And you can see the results here in this report of hemorrhage into the brain. And so this is obviously if there's a hemorrhage, that's a much more severe situation than the ischemic occlusion ever was. So the carotid cut down technique, I'm sure everyone's familiar with this, where we gain distal and proximal and distal control of the vessel. You can place a purse string suture and then access directly through that approach. There's also the TCAR method where you can use their proprietary technique, proprietary catheter in-route system to be able to access the carotid directly. And this works quite well also. You can see the directionality of flow is reversed after this access is achieved with the distal flow going into the femoral vein. This also achieves the goal of being able to reverse the flow in these cases. And in these cases, oftentimes we see debris in the filter. This is the TCAR filter that you can see here in the middle, and often there is debris. As a counterpoint, when I do these procedures antegrade for conventional carotid stenosis, we use these various filters, and I very rarely see any embolic material in those cases, but I very commonly see it in these TCAR approaches, which tells me that these distal embolic protection devices just are not very good. And I believe that the reversal of flow is an important concept. So we are part of a study sponsored by Silk Road. We were one of the 10 sites in the US. It was a night one trial. And unfortunately, due to a number of issues, mostly consenting acute patients, we had poor recruitment, difficult to obtain consent from the families of these patients. They're coming from distance, and our review board and most review boards required that consent be obtained in person, which is a difficult situation. But suffice it to say, it was stopped early due to poor recruitment. However, in the few cases that we did, it provided some benefit. So this is a study where this is a stroke from acute cervical internal carotid artery occlusion. This is an older study you can see from 2012. We had 21 patients. TPA was given in 13, and the indications for this were treated either endovascular in 8 cases or rescue in 3. And in those patients, a good MRS-02 was achieved in most of the cases with good results. So thromboendarterectomy has been around for a long time, by my mentor, 𝒂𝒄𝒔, where direct carotid cut down can be performed, and the endarterectomy can be addressed as well as the site of occlusion in the same setting. And here are the results of that study done way back in '92. And I think a lot of these techniques have a lot of merit and have sort of been inappropriately abandoned with the endovascular techniques. Sort of we get into our box of, okay, we can do this. This is a procedure done endovascular, and we have to do endovascular, or this is a procedure that's done with open surgery, we need to do open surgically. But in fact, there's opportunities for converting from one to the other. Here's a case where you can see the tortuosity of the carotid proximally, and then you can also see this distal occlusion of the carotid. You can see this flame sign indicative of there being thrombus present there, a very significant mismatch in the cerebral blood flow and Tmax with a lot of brain at risk. And in this case, we elected to perform a thromboendarterectomy, so we converted immediately on the table to an open surgery to address this occlusion. And so you can see here, the common is occluded, the external was occluded there with a clamp. We're incising into the internal carotid, or sorry, the bifurcation there of the common and external and internal. And then you can see there's no backflow initially because there's a thrombus there. And then as we suction out the thrombus, you can see that that's suctioned out. The internal is then occluded. We can complete the endarterectomy. You can see the size of this thrombus is also, this is a 9 French suction that we're using. And we do not use sheaths that large. Usually 8 French is the largest size. And you can see the size of this thrombus. It'd be very difficult to see a scenario whereby we'd be able to retrieve this thrombus through an 8 French sheath, conventional sheath, due to the size of the thrombus and the extent of the material, thrombotic material. And this is a post-procedure, the same patient. You can see with a very good radiographic and clinical outcome. Tandem occlusions can be also addressed very easily in these cases after carotid cut down. You can see here that there's 2 sites of occlusion, one at the site of the internal carotid artery and one at the site of the middle cerebral artery, the distal temporal M1 here, where the site of the occlusion, where there's a tandem occlusion. So in these situations, once the carotid cut down has been performed, the catheter can be advanced through that, and very easily we can achieve an excellent recanalization using then standard endovascular techniques. So I think the pros of endovascular access would be that the access time is short and the workflow is very familiar. Many places don't have a hybrid operating room, so I don't fault them for that. But because of that, it's very easy to continue on this endovascular approach. However, the issues with endovascular in these cases of carotid occlusion, where the bifurcation is open, is that they may require a stent, where the likelihood of hemorrhage can be much higher, and the likelihood of non-targeted embolization when we go through the thrombus in an antegrade fashion, where the carotid, where the terminus is not occluded, may result in non-targeted embolization. For open surgery, I think it's quite definitive. It's very simple. The access time for those familiar with cutting down on a carotid is very short. It's not as long as people perceive it to be, I think. And when compared to a difficult endovascular access, I'm sure many in this panel here have spent more than 20 minutes trying to access these difficult lesions. The main difficulty with these approaches is that there may not be a hybrid operating room available to be able to do that in. So some of the questions that we have still are, should thromboendarterectomy or direct carotid access be used upfront when we perceive the anatomy to be difficult, proximal and distal tortuosity, or in a salvage type situation? And I think that it's difficult when we look at the CTA ahead of time to know exactly where is the site of the occlusion. Is the site of the occlusion down proximally, or is it further distal? And this has a lot of bearing as to how the what approach to choose. Also, the patency of the carotid terminus, I think, is a key factor as well. So in my experience, over about 13 years now, we've had 42 endovascular failures. We addressed these with a carotid cut down and patients' CTAs of likely extracranial internal carotid artery occlusion. We use that either in an upfront method where it seems like where the terminus is open and the internal carotid artery is occluded, more proximal to the internal carotid artery bifurcation, or where there's inability to traverse the stenosis endovascularly, as can occur, instead of using very aggressive techniques like using large guide wires, etc., to try to traverse that. If it's not working with the standard technique, we would convert to an open procedure. We're using more and more ultrasound to try to help identify situations where the site of occlusion is, since CTA does not seem to be a good predictor of the site of the occlusion. And we're still sort of determining what are the best grayscale and color ultrasound methods of determining that site of occlusion. So with that, I'll stop. I hope I'm close to the right amount of time for this presentation. I thank you for your attention.
Thank you very much, Professor Azam. Let me invite our chair, Professor Zhu, for his comment first. Professor Zhu.
Thank you for Professor giving us a wonderful speech of the direct carotid access for the acute ICA occlusion. It's well known that the endovascular treatment for the acute ICA occlusion can be accessed by the femoral artery or radial artery, and then direct the carotid puncture access is seldom used. Only when we encounter the failure access from the femoral or radial artery. So I think it's very good and provide an alternative approach to treat the acute ICA occlusion. One important question is, as the speaker said, it's better to know what side of the occlusion, just the CTA and the extra cervical artery ICA is most common the site of the occlusion. So if the occlusion site is located at the ICA terminal of the ICA, I think the direct puncture maybe is useless. So I have no questions. Thank you.
Thank you, Professor Zufan. Now we go to Professor Mozonsky. Professor.
I hope I'm correct. Azam Ahmed.
Yes.
Yes. It's a great presentation, and first time direct puncture we did in a patient with the aorta coarctation. With the occlusion, and it was no access. And at that time, it was 15 years ago, and we did a direct puncture with 6 French introducer sheaths, short one, and we used in young child envoy catheter and just manual compression used for the hemostasis. And I know many colleagues using this simple technique with manual compression and comparing with the femoral artery. Usually, deadly hematoma is not possible in neck region. It's very effective technique, and I think it's one of the approaches, and it should be used. And before I came to the vascular neurosurgery, in my internship time, we did a diagnostic angiography in Long 2004, 20 years ago, with direct carotid puncture. It was just a puncture and the angiography. I think in Soviet period of time and post-Soviet countries, it was regular practice to do carotid angiography. And the femoral approach I learned in 2008, just in 4 years. And nowadays, radial approaches came, and more and more young colleagues doing radial approach, and the direct puncture in stroke cases mostly, when you could not spend a lot of time for the access. I think the direct puncture is brain saving technique, and you very nicely explained. Just one point, in a kinking or coiling of the extracranial ICA, we're using so-called tonsillar loop technique we learned from René Chapeau, and nowadays it's very easy to straighten the course of the ICA, and usually 2 carotid stents, one Casper and one regular carotid stent we use to straighten the course of the ICA. But in a stroke cases, it could be more aggressive because you need to give antiplatelet therapy. But in plant cases, it could be one of the options, and the kinking and coiling, it's very easy to straighten with the endovascular technique. But you showed very good technique of combination open access with endovascular. Thank you.
Thank you.
Thank you, Professor. I can I ask question, Professor Azam? Thanks for
Absolutely.
a nice lecture. 2 questions, Professor. One, in United States, who are the person that been given credential and privileging to do carotid cut down? Is that only surgeon or also intervention radiologist? My second question, Professor, you talk about flow reversal using TCAR. And if you compare with the balloon guided catheter, what are the differences? Which one can have better reversal flow? Thank you, Prof.
Yeah, good questions. Yeah, so I think it's a very political point of who can do carotid interventions. And certainly that's privilege is only given to surgeons. And in many cases, it's still a battleground in the sense that vascular surgeons may not allow the neurosurgeons to be able to do these carotid procedures. However, I think that's a very antiquated concept. We do, in our department here, we do an equivalent number of carotid endarterectomies compared to our vascular colleagues. So we do them a lot. And I think that facility allows us to be able to then, offer that technique and not have to worry about being viewed as, what are we doing if we're doing this in a, one-off setting, or if we do this routinely, this just becomes part of the things that we're able to do. So, yeah, but it's not that's not given to radiologists or to neurologists to be able to do. It's strictly a neurosurgery privilege. at most, at least academic centers in the U.S. Private hospitals may be more guarded and reserve that only for the vascular surgeons. So, and then your second question was regarding
reversal flow.
Oh yeah, reversal flow. Yeah. So the differences would be that I think it really depends on where the site of the occlusion is. So if you're trying to occlude, let's say the carotid bifurcation is occluded, and the site where you can get the balloon catheter is the common carotid. I think it's often difficult to achieve enough reversal of flow through a 6 French balloon guide catheter. And even with an 8 French, it may be difficult to overcome the backflow from the external carotid to achieve a good reversal of flow with the balloon guide catheter. That's my educated guess, having done it both ways. With the TCAR sheath, it's an 8 French sheath. But it's not the same as a endovascular 8 French sheath because the sheath is very short, so the resistance is quite low. And in those situations, in the vast majority of cases, we're able to achieve reversal of flow by just simply and overcome the backflow from the external carotid. Now, if the site of the occlusion is further distal in the internal carotid, then I think it becomes more of an option because the internal carotid artery, you don't have to, if you're putting the balloon in the internal carotid, you don't have to worry about the backflow from the external as much. And then I think it's a more viable solution.
Thank you, Professor. Probably hear a comment from Professor Yoko Kato, Professor.
Dr. Azam, thank you very much for the excellent talk. I think, of course, the hybrid neurovascular treatment is very, very important, especially it's a very difficult case, I think. About that, just I want to know your situation at your institute, the follow-up system, because in Japan, especially our system, we have so many cases, FT or a WEP. Then every 3 months, 6 months, 1 year, we do the follow-up of those cases by angio. I think it's too invasive for the patient. What about your institute? Do you do the still angio or CTA or some other devices?
Yeah, that's a very good question. So we use, for most endovascular devices, for their follow-up, we follow them up with MRA, MR angiography. I think the classic teaching was for pipeline flow diverters and intrasaccular occlusion devices was angiography, and the trials used angiography. And I think that was important at the time of the trials. I think now, as we've gained more experience, I think it's the MRA, very, very uncommonly does the MRA give us false negative or false positive results. And so I think it becomes more of a matter of habit as opposed to necessity to answer the question. So I've abandoned the 6-month follow-up angiography personally for flow diverter cases. And if I don't see that there's filling on the MRA, then that's sufficient. And that's worked well for me. But I would say that I'm certainly in the minority at my institution. My other partners all do follow-up with angiography. Now for aneurysm clippings, that's a different scenario because of the artifact that the clip causes. So my preference in those situations is to do an IV DSA, so not an intra-arterial access, but IV access, and then do a DSA in a 3-dimensional spin. And that and our institution works very, very well. So that'll be my first baseline follow-up on the table for that patient. While make sure that along with ICG, we all know that ICG is not perfect and have cases where the ICG either indicates filling and there's no filling of the aneurysm when we poke it with a needle, or vice versa, that the aneurysm is completely occluded and yet when we poke it with the needle, it still flows. So ICG, I think, is a good tool, but it doesn't replace angiography. And the ability to do IV DSA, if you have a hybrid operating room, is very easy, very simple, and straightforward. So even in elective cases, I will do IV DSA as my baseline imaging. And then I will follow up the patient at 1 year, often with a conventional angiogram, or an IV-DSA. And then my follow-up scheme there is usually 5 years and 10 years thereafter, either IV, DSA, or angiography.
Thank you very much. So, excellent talk. Congratulations.
Thank you, Professor Azam.
Thank you.
Now we come to the end of today's web seminar. So I would like to thanks our both speaker, Professor Nakahara and Professor Azam Ahmad, for your nice presentation, and to our chair, Professor Feng Zhu, and also to our discussion today, Professor Mozansky. And before I close the session, probably I would like to invite Professor Kato for her closing remark. Thank you.
Well, thank you very much. So it's era of the endovascular. So in my institute, almost aneurysm cases, maybe less than 5% for the clipping. So I think it's very ideal. But I am an open surgeon, but sometimes I feel, and of course, the endovascular is very less invasive for the patient, but many times follow-up is too much sometimes for the patient. Sometimes is some leakage of the blood. So of course we do the peripheral radial approach, but sometimes compartment syndrome of the one arm. So I think such disadvantage should be I think solved in the future. Then more people like endovascular treatments. I think, but anyway, thank you very much for the pen and also the Menchilki. Thank you very much. Now your student is working very well with us now. That he will leaving very soon, but he's writing so many papers now. Anyway, thank you very much. Thank you.
Thank you, Professor Kato, and also thanks to our audience for joining us today. So we are going to close the session now, and we see you again next month. Thank you, Professor. Bye-bye.
Bye. Thank you.